My topic for discussion and presentation is lorlatinib in the management of ALK rearranged non-small cell lung cancer, and primarily it will be the first line treatment. Starting with the first slide, what we know that as the time has gone by, we have learned to talk about non-small cell lung cancer not in terms of only the histopathology. You want the subtype of histopathology and also the molecular classification. These are the numbers of lung cancer and today and the expected in future. And we do expect the numbers to go up as compared to what we see today. What has not been heartening, as we have seen in worldwide, the number of patients dying because of lung cancer has been decreasing at a very good pace, but that's not what we see in our country, and looks like we need to detect them early, and also we need to ensure those effective treatment, which we'll be talking about, they need to reach as many people as possible. And that could be the reason, because it is not reaching and nor we are detecting them early, our outcome looks different from the Western world. Coming back to the ALK mutation, and overall, if we see the incidence, it appears it varies from around 5% to 10 to 11%, depending upon which data and which time frame you see in our country. But it appears, if you see the data overall, looks like ALK mutation positivity, since the IHC has been introduced, is a bit on the higher side as compared to worldwide data in India. Now, coming to rearrangement of lung cancer for ALK, as I said, it varies from around approximately it is 5%, but it varies from which data you see, but it is on the higher side. More commonly in adenocarcinoma patients. We do know if you have a non-smoker squamous cell carcinoma, don't forget you do get one of them as ALK positive patients. Typically, more of them, they are non-smokers, but smokers may also have it, so that can't be the reason not to test it. It appears to occur more in the younger patients, and also depending upon the diagnostic technology which we are using. Usually mutations are exclusive with each other, but more we are using the NGS technology, where it appears you do have 1 to 2% of the patient where you can have mutations which coexist. A bit about ALK inhibitor development, and this has been one of those development which has been fast-paced and has been result-oriented. Starting with 2012, where you had the first drug crizotinib approved. Subsequently, we do have ceritinib, alectinib, brigatinib. The data is there for ensatinib, and then you do have lorlatinib, which was available in the market, and now it is also approved in the first line setting for ALK positive non-small cell lung cancer in advanced disease. Now, coming to the current treatment options and the unmet need for ALK positive non-small cell lung cancer patient, as we have seen, you do have many options. One of the challenges has been that if we use the early generation drugs, you do have a significant proportion of patients who develop brain mets. And in general, also the patient with ALK positive patients, they have a higher brain mets as compared to the patient who are mutation negative. It also appears that they do better when we use the first generation or second generation TKI in these patients as compared to chemotherapy. But most of the patients, they do develop resistance after average of around 10 to 12 months of this TKI. So that remains another important challenge, that how do we have those sustained responses in these patients. Lorlatinib is one of the drugs, which is a selective ATP competitive, highly potent third generation ALK inhibitor. It has excellent brain penetration to address the brain mets. It has a potential to improve the clinical outcome with overall and intracranial activity in the patients with previously untreated ALK positive patients. In addition, upfront treatment with lorlatinib could completely suppress or at least significantly delay on-target resistance, leading to more durable clinical benefit. So two limitation of the previous generation TKI can be overcome with this drug, where it has a good brain penetration, and also the activity appears to be higher than those drugs. Coming to a bit about the design of this drug, and this design of this drug, and this is one of those rare drug which was a designer drug. We had the crizotinib. There was in the lab where it was thought that if we design in a certain way, this drug should be beneficial in these patients, overcoming the resistance and also having effect on the brain mets. And this was one of the designer drug which was clinically successful later on in these patients. You had initially the trials in the second line setting, which led to this trial to happen, what we all know about, called as a CROWN trial. And this was a randomized trial comparing lorlatinib, that was 100 milligram daily, to crizotinib, that is 250 milligram BID. These were the patients who were stage 3B or 4, which was ALK positive, treated with palliative intent. They were treatment naive, ECOG performance status 0 and 2. Asymptomatic, treated or untreated CNS mets were permitted. One or more than one extracranial measurable disease was important, with no prior radiotherapy being given. The primary endpoint was PFS. There were secondary endpoints for overall response rate, the overall survival, safety, and quality of life for these patients. The study conduct: 296 patients were randomized, 149 in lorlatinib and 147 in crizotinib arm. 5 patients in crizotinib arm did not receive treatment. All patients underwent staging with chest and abdominal scan and brain imaging every 8 weeks. And this was the interim cutoff data, which will be I'll be talking about. This is the baseline characteristics. And in these baseline characteristics, it looks like age, gender, race, performance status, smoking status, current stage of the disease, brain mets as baseline, and prior brain radiotherapy. They look like fairly well matched in these two arms. Coming to primary endpoint, the primary endpoint, the median PFS was 9.3 months in crizotinib arm, as compared to the PFS which has not been reached in patient receiving lorlatinib. For me, the more important was that the patient at 12 months had a 39% progression-free survival patient receiving crizotinib, as compared to 78% of the patient in lorlatinib arm who were progression-free in these patients. That is almost 40% more patients being progression-free at 12 months if you give lorlatinib as compared to crizotinib in these patients, with the hazard ratio 0.28 and p-value being significant. Now, this kind of hazard ratio and these kind of differences we have not seen in the past, especially when we are comparing one effective drug against another effective drug. What I mean to say, you have a TKI, which when came in the picture, we have all thought, especially I have definitely thought, that crizotinib will be tough to beat by subsequent therapy in future. This is the PFS by investigator and suggesting having a similar outcome in these patients. If we see the subgroup analysis, it appears in the patients with the brain mets, patient with different ethnic origin, patient divided between the performance status, patient divided by gender, age, smoking status, and histology. It appears it benefits in all group of patients, and hazard ratio remains strikingly meaningful in almost all group of these patients. Overall response rate was higher in patient receiving lorlatinib, that was 76% as compared to 58%. And duration of median response was 11 months in crizotinib as compared to not reached in patient receiving lorlatinib. Time to median response was similar between these two arms, that was 1.8 months. It appears that most of the patients, they do respond within 2 months when you give either crizotinib or lorlatinib. This was the important issue for the newer drugs when we talk about in the ALK positive patients. That is what happens to intracranial responses. Here it again appears that intracranial responses with crizotinib, when it is around 23%, it is around 80% plus when we give lorlatinib to these patients. Highlighting again, it has a strikingly useful intracranial activity in the patients who are ALK positive and who has brain mets. Another way of looking this data, that what is the intracranial time to progression in these patients. And what we see here, that in these patients, the intracranial progression in lorlatinib is hardly any as compared to crizotinib, which is a limiting factor in patient receiving crizotinib. Overall survival, this data is immature, but as we can see at all different time points, the events in patient receiving crizotinib is higher than the patient receiving lorlatinib, but sure, we all need to wait till this data mature, and I'm sure that will be eagerly waited, and especially comparing this data with the alectinib in the first line setting, where we do have one survival data which is positive and survival data from Japan which is not positive. So I'm sure we all will be looking for what happens to this drug, which is strikingly useful as far as progression-free survival and control of the disease in brain is concerned. Coming to safety summary, this drug has some safety issue, but if we see that if we manage them appropriately, then the serious adverse event, the fatal adverse event, that looks similar between the two arms. But important is to understand how do we manage those side effects, and also adverse event leading to temporary dose interruption also appears similar between the two arms. This drug has got some striking side effect which is different from the crizotinib, that is the effect on the cholesterol, fetal edema, weight increase, peripheral neuropathy, and cognitive dysfunction. As compared to crizotinib, which has got more of a vomiting, nausea, then you have liver dysfunction and diarrhea, which is far more in patient receiving crizotinib as compared to lorlatinib. So these two drugs having a different kind of side effects, but it is important that this drug does have some side effect which we require to learn to manage early. This is the quality of life data, and what they suggest that quality of life was far better in patient receiving lorlatinib as compared to crizotinib when global quality of life difference was analyzed in these patients, highlighting that it does as the time goes by. Lorlatinib leads to a better quality of life in these patients as compared to crizotinib. In conclusion, lorlatinib resulted in a significantly longer progression-free survival, significantly higher overall and intracranial responses in these patients. It improved quality of life compared to crizotinib. Again, I need to repeat, it is not easy to have a better outcome in this clinical parameter, and especially in quality of life, it is very uncommon that one drug shows a better quality of life as compared to other drug, and that too comparing with crizotinib is fairly uncommon. Safety profile, yes, we do have a different kind of side effects with these drugs as compared to crizotinib, but yes, one needs to learn to manage them appropriately. Based on this data, this drug is now one of the drugs which has got FDA approval and also is recommended by NCCN as a treatment option in these patients. As I said, that we need to learn about managing the side effects. One of the important aspects is lipid lowering therapy. In my practice, almost every patient has required this. So we need to be careful that as early as possible, once your cholesterol is going high, it's good to start a lipid lowering agent, and especially where they do have lesser impact on cytochrome P450 enzymes so that they don't interact with the drug. Make patient aware that regular monitoring of serum cholesterol and triglyceride is needed, and the moment it is on the higher side, it is good to start the treatment so that we don't have to deal with really significant higher the drug level in these patients. CNS side effects. This includes changes in cognitive function, mood and speech, generally mild in severity, intermittent, and improved or resolved upon dose modification. These ADRs were reported at a frequency of 39%, with 11.9% of patients experiencing more than one type of CNS side effects. Baseline CNS Mets were present in 71.8% of patients with CNS effects, suggesting some correlation with them. A total of 24 patients required more than one dose modification as a result of CNS side effects. It also appears that good number of patients, they had a resolution of CNS effects once this drugs dose modification is done in these patients. And mean time to resolution was around 12.5 days, suggesting by 2 weeks, one should know that yes, the patient responded to the side effect or not once the dose is changed in these patients. Recurrences of CNS effects upon re-challenge at the same and the reduced dose occurred in 6 and 7 of the patients respectively. So it becomes a challenge if you're giving the dose, going back to the dose to see that what happens to the side effect in these patients. Dose modification guidelines for lorlatinib has been there for CNS effects by CTCAE grade. And what we can see here, this is useful to have in our clinic so that one can change the dose and go back to the dose as per the instruction in the leaflet. Coming to our own experience with lorlatinib, this is the initial experience when it was available on the compassionate ground. We had around 41 patients. These are the patients, majority of the patients being male, but good number of patients being female. There were a good number of patients who had some comorbidities. Majority of the patient had some previous line of therapy which was given to them. Majority of them be having the TKI. These were the site of Mets where we have in these patients. These were the toxicity, similar to what we have seen in the literature. Peripheral edema was not so common, or maybe because of retrospective data, we could have missed it, but that's not what we saw commonly here as compared to what we have seen in crizotinib. These were the site of progression where the disease progressed when we gave this patient lorlatinib. And subsequent to lorlatinib, these were the different kind of drugs. There's chemotherapy and different chemotherapy because we wanted to know what happens to them when there's a disease progression in these patients. But we were able to give subsequent chemotherapy in these patients. Duration of response. This swimmer plot suggests that good number of patients lorlatinib can have a sustained response if we give them in these patients. This also gets reflected in our PFS data, and what we see here, these patients in second line setting are the patients who are intolerant to the first line treatment. The median PFS in our population, that is the clinical use, was around 20 months. If you see the survival, the median survival was around 23 months, but that data is immature at this moment in these patients. If we take these patients who received lorlatinib from the day one when they had the advanced stage disease, that is from day one when they started on systemic therapy and they received subsequently chemotherapy or crizotinib and they went for lorlatinib, the median survival of these patients were 64 months in this group of patients, suggesting that if you have ALK-positive patients and if we are able to expose them to the third generation TKI, then the overall survival of these patients are significantly longer. Thank you. Thank you so much.